Good morning. I'm Dr. Ara Dukmajian, CEO and founder of the Duke Spine Institute. We're here in the operating room at the Surgery Center Vieira, our partner facility, where we do all of our surgeries. We live stream every surgery. Today we're going to start our day off with a patient who injured their neck in an accident, has multiple disc herniations. The worst one is C4-C5. We discussed treating all of them. He only wants one fix, C4-C5. We respect his wishes. We're going to be fixing C4-C5 today. His choices for surgery, because he has a herniated disc at C4-C5 causing neck pain and arm symptoms. His choices are anterior cervical decompression and fusion, which is an ACDF, very common procedure, artificial disc, laminectomy, foraminotomy, and endoscopic Duke laser disc repair. He's chosen the endoscopic Duke laser disc repair. I asked him yesterday, why did he come here for the surgery? He said he did his research on the internet. He studied all the different surgeries. He recognized that the Duke laser disc repair is the safest and most effective surgery with the fastest recovery. That's what he wanted, the best. Of course, at Duke Spine Institute, we do all surgeries here: laminectomy, foraminotomy, discectomy, fusion, artificial disc, and endoscopic. So we're capable of doing any surgery. He chose the least invasive, most successful surgery. So we're going to get started. We're going to use X-ray to localize and navigate. Localization means it tells us where we are. Navigation means we navigate. All right, so 2, 3, 4, 5, perfect. AP, quickly. So we're going to switch from a lateral to an AP X-ray view. And this is image-guided surgery. We use X-rays because that's perfect lateral. You can see that the needle is just about the midline of the spine. And we've been doing this procedure here at Duke Spine for 16 years. Shot. It's too low. And shot. That's perfect. Shot. AP. So I need to see that the needle is, I know it's at the right disc, C4-C5, but I don't know if it's in the midline until I get an AP view. And it is in the midline. That's perfect. You can see the spinous processes. Go ahead and show them the spinous processes. So keep the X-ray. You guys see the spinous processes? Show them the needle tip right there, and show them the line of the center. Yes, it connects the spinous processes. So we're right in the middle. It's perfect. Lateral. I've already pushed through, and let's count our vertebrae. 2, 3, 4, 5. We are at the C4-C5 disc. Everyone agree? Yep, I agree too. And that's what we're supposed to be operating on. So we're doing everything right. We're going to start with a discogram. Now this is not an evocative discogram. This is just a chromodiscogram, meaning we're adding dyes. 2 types of dye. Number 1, our Duke laser disc repair dye shot. And number 2, I'm adding the shot. Let's just make sure where we're supposed to be. Good. All right, I'm going to go ahead and inject. We're adding on the pig. There we go, shot. All right, look at that. So let's pull the shoulders and let's get another shot. Shot. That's better. I need you to inject just a little bit. Look at the dye has leaked out. Shot. All right, so that's good. The dye has leaked out through the disc, and the disc is so damaged that the dye has gone out through the tear completely into the epidural space. Yep, that's what we're seeing there. So at this point, we've done our discogram, and I'm going to add the guide wire shot, and I'm going to take the needle out after I make an incision. Now, the incision for this surgery is only 4 millimeters. You guys know how small 4 millimeters is? Tiny. We do this endoscopically. The incision at 4 millimeters is for one purpose. That's to put the tubular retractor in. The tubular retractor is the tube that we're going to do the entire surgery through. So most surgeons who do disc surgery make a big incision so they can see down there. We're doing the whole surgery through this tube. You guys see this?
Yes, we do.
It's like literally a coffee straw made out of metal. So we're going to have this in that incision, and the width of this is 4 millimeters. That's why we only need a 4 millimeter incision. This is the most advanced degenerative spine surgery in the world. You cannot get more advanced surgery than this. 4mm incision. 99% of spine surgeons don't know how to do this kind of surgery. Sean? So they're still doing fusions and artificial discs, basically putting metal in your spine. Of course, they're financially incentivized to do that. So why do so many surgeons do metal surgery? Because they make more money doing metal surgery, putting metal in you, okay? That's what we're trying to change. There's no need for that metal. It's totally unnecessary. That metal causes complications. It's very expensive, and it's dangerous for patients. So patients shouldn't be getting it, but they get it because their surgeons don't tell them about endoscopic surgery because they don't know how to do it. All right, now we're in the front of the spine. I can feel the ALL shot. Let's go with an AP view. I want to make sure I'm in the middle. So by the way, our patients from Tuesday are doing fantastic. I saw them in clinic yesterday. The nurse from New Jersey, all of her back pain completely gone. Show them the tip of the dilator right in the middle.
That's such great news.
Yeah, all of her back pain was gone, and you know, she had an interesting finding. She had some numbness and weakness in her foot after surgery. We were scratching our heads why, but we knew that we gave her a lot of local anesthetic, this Marcaine and lidocaine, a lot of it, because she didn't want fentanyl during the surgery. So we had to control her pain. We gave her a lot more local. It ended up that the local caused her nerve to be numb, basically. So it threw us for a little bit of a loop. But the next day, I mean, she was moving her foot really almost 100% normal. So yeah, that takes a long time for that to wear off. But yeah, she's very happy. She went back to New Jersey pain-free. The Duke Laser Disc Repair Cervical, remember the C6-7, C7T1? That patient's pain is 100% gone in her neck and arm and no headaches. She's very happy. She's had it for a long time. And of course, the other patients all had excellent results with no more back pain. Even the Duke plasma rhizotomy came in with 0 pain. He was a bilateral 3-4-4-5-5-1. He was very happy. He actually was so happy, he came in with the ingredients for his secret pepper that he makes for everyone. And he gave me, he's the hot sauce king, and he gave me those ingredients, which I cannot share with you. Anyway.
KFC, those ingredients.
Yeah. No, I think it's fascinating, you know. When my dad was practicing, his patients were so happy they would bring all kinds of things for him, you know. And he loved it. He always brought them home for us. All right, let's get an AP. Did we do an AP? Before you go AP, show them on the lateral view the tip of the dilator, the tip of the tube, outside the disc, how it's going to go through. And let's see the esophageal temperature probe. So there's the tip of the dilator at the back of the disc, right where the herniation is. There's the tip of the tube. We haven't gone through the disc yet. There's the esophageal temperature probe. And there's the endotracheal tube in the trachea. Okay? And now let's go AP. Perfect. So you can see the tip of the dilator at C4-5 heading off to the foramen on the right. You can see the tip of the tube in the front of the disc. Look at the esophagus. Pretty cool, huh? How it wraps around to the side. So you can see we moved it out of the way. Show me the endotracheal tube, which is the continuous line. That's correct. So we're not going through those structures, we're going around them. All right, let's go ahead and show our audience the why does a herniated disc cause so much neck pain, arm pain, and headaches. I'll give you a hint. It's from inflammation. Dilator, move back a little bit. We're going to have to move it forward. Go ahead and start that video, Henry.
Traumatic injury on the disc can cause annular tears to form. Pressure on the disc causes herniation of the nucleus pulpus through the annular tear. inflammatory tissue develops within the annular tear, causing neck pain. The inflamed annular tear generates pain signals. Additional injuries can cause worsening symptoms. Inflammation from the annular tear can spread to the nearby nerve roots, causing arm pain. Pain signals travel up the nerves to the brain, causing localized neck pain. Pain signals reach the primary somatosensory cortex, causing conscious awareness of neck pain. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
All right, welcome back. We are now just starting to go down the tube. Can you guys see the endoscopic view?
Yes, we can.
All right, so this is the C4-5 disc, correct? And we've got herniation right here. And the tube is literally docked at the back of the disc where the herniation is. This is herniation. It's scarred. The blue stuff is a blue dye we put in earlier. No, it shouldn't be there. Great. So how does this surgery work? You see the laser there, folks? That is a 0.5 millimeter, 0.5 millimeter. The width of that glass. It's at 12 o'clock. You guys see it? All right. So just to give you an appreciation of how small this stuff is, it's tiny. You know, that laser fiber is 0.5 millimeter. So the width of the inside of the tube is around 2.8 millimeters. Okay? It's not a lot of space, and it's enough to get the surgery done. It's enough to remove the herniation without damaging the rest of the body. The only damage this patient is having from our surgery, guess what that is? It's the skin incision. 4 millimeter incision, that's it. Nothing else is being damaged. Everything below the skin is actually being spread apart. Your body has fibers in it. Okay, fibers are basically strands of tissue, whether they're muscle fibers or they're connective tissue fibers or they're bone fibers. You know, the skin itself is an epithelium. It's a solid layer of tissue, so you have to cut it. You can't spread it. Okay, you can poke it, but that's not the same thing as spreading. The rest of the stuff under your skin is all fibers, and fibers are like cloth fibers. So if you take a safety pin and you push the tip through your clothing, the tip of the pin doesn't destroy your clothing, does it? No, it creates a small opening, and then you take the pin out and those fibers come back together. So you haven't destroyed anything, you've just spread it. That's what we're doing, we're spreading. Other surgeries, they destroy. That's why you get so much bleeding, so much scar tissue, so much pain after the surgery, because the surgeon is destroying your body in order to fix it. We're not destroying your body. Therefore, there's no pain after the surgery. Patients have mild discomfort in the back of their neck or base of their neck for a day or two, and then it goes away completely. So when you have surgery and you have a lot of pain afterwards, that means your surgeon did some destruction, okay? And you know, it's inevitable to have some destruction with surgery, but you want to minimize that destruction and trauma. To do that, you want to select a surgery that's the least invasive. By the way, see those fibers down there running left and right? Those fibers, those are the posterior longitudinal ligament fibers. I'm at the back of the disc. This is all scar tissue, and you see the gold color is calcification. It's called dystrophic. Oh, look at the herniation that just came out. Beautiful. All right, there's one. That is a herniation, folks. That's the nuclear material that pushed out of the disc through a tear in the back. Now, do we show the video on how the Duke laser disc repair actually works?
Not yet.
Let's do that now.
Disc herniations are a common cause of chronic neck pain. The inflamed annular tear causes neck pain. Inflammation of the nerve roots causes arm pain. A Band-Aid-sized skin incision is made. A small tube is inserted without damaging the bone or soft tissues. The laser removes the herniation and debrides the annular tear. The annular tear heals on its own. It can take up to 12 months. If you have a herniated or bulging disc and neck pain, submit your MRI for a free review at www.mri.dukespine.com.
Welcome back. We're removing herniation right off. Oh, there's another herniation right there. All right, that's a big one. Remember, the inside of the tube is around 3 millimeters. So that herniation is around 3 millimeters. Okay, then that's a herniation. Notice that. That is literally a chunk of material that squeezed out from the disc and is now sitting on the spinal cord and nerve roots, which are down there. Okay, so that is a herniation. Each one of these is a herniation, by the way. And so what happens is you get trauma to your spine, some type of trauma, and it causes a tear inside the wall in the back called the annulus, and that's what we're looking at. We're literally looking at the torn annulus right here. That white stuff is the torn annulus. It's scarred up. And then through that tear, pieces of nucleus, which normally stay inside the disc, they push out. There's the foramen. And when the pieces of nucleus push out through the tear that's there, that is called a herniation. Okay? Now everybody thinks you have to have a big herniation and need surgery. That's not true. That's been the old way of thinking. It's the wrong way of thinking. And the reason is that these herniations, the small ones, even the small ones like this, cause severe pain. And they just destroy lives. People can't do anything. They're incapacitated from the pain. And the pain, as you can see, is inflammatory pain. Comes from inflammation. Grabber. So inflammation happening in just the right spot can be just debilitating, right? All those painful conditions, whether it's shingles. You guys know what shingles is? It's herpes. It's an infection by herpes zoster, and it infects your nerves, and it travels from the nerve, dorsal root ganglion, out to the skin, and it causes the most painful condition you can imagine. Shingles, right? People just hate it. It's so painful. Cool, huh? Anyway, long story short, the shingles cause severe pain through inflammation. All severe pain comes from inflammation, except for a condition called trigeminal neuralgia and some other conditions like reflex sympathetic dystrophy, which are abnormal nerve connections, okay? But this condition is an inflammatory condition. Herniated discs are an inflammatory condition, and nobody knows that. And doctors talk about compression. It's not compression that's important. That's also important because it causes spinal cord damage, nerve damage. But inflammation is far more common than compression. And that's what needs to be treated. That's a bone spur right there. Now, I know this patient had an injury a few years ago, and I could tell you that what I'm seeing endoscopically lines up, definitely lines up with the age of his injury. Yeah, a lot of these herniations appear to be around that age. Okay, I can't go into details, but I can just tell you that. Can't go into details because of patient privacy. I don't want to say too much. Okay? I don't want to give away anything that could help you identify who this person is, okay, publicly. So we just have to be careful what we say, respect patient privacy. Now, all of our patients that have a broadcast, they all give us permission to do the broadcast. So we're doing the broadcast with his permission, and our job is to not disclose this patient's identity to you, the public. He can disclose the identity to you, but we cannot. So we respect our patient's privacy, and we do everything we can to prevent any kind of disclosure of information that would identify the patient. We got 5 minutes and we'll be done. Remember, we're only fixing one disc today. This patient has more than one disc. I recommended more, but he could only do one disc. He chose to do one disc, and that's why we're here doing one disc. These are all herniations, by the way. That's another one. We've seen a lot, right? I stopped counting. At least 15, maybe 20. Question? Henry, are you there?
Yes. Sorry. Having a conversation with Carl. Yes, we have a question from a Meowasaurus on YouTube. And they said, I had a discogram done recently. What makes it so painful in only my bad disc?
Great question. So somebody had a discogram, a wonderful diagnostic test that we use here. A lot of doctors don't believe in discograms, but they are absolutely great tests. Unfortunately, they're a bit invasive, so you got to stick a needle in the disc. So what's happening is you have inflammation going on in your painful disc. And think about having a pimple on your face that's really painful, right? You leave it alone, it doesn't hurt so bad, does it? But when you take your finger and put pressure on that inflamed tissue, it hurts like hell. That's what's happening in a discogram. You have an inflamed disc, and when you do the test, you're putting dye in there, and you're putting pressure on that inflamed disc, on that annular tear where the pain's coming from. And that activates, the pressure activates those nerves that are so angry from the pain. So it's just a test, and it works really well. We do it all the time, and it gives us valuable information. Just about done, probably another minute, maybe 2. Let's just keep seeing more herniation fragments. Again, look at all these herniation fragments, folks. This explains herniations are not one-time event. The damage to the disc where you get the tear, that's a one-time event maybe, or 2-time event. But the actual herniations just keep happening as long as there's a tear, which is why I know this is going to sound amazing. Nobody's ever said this in the year before the year 2023, before I've said it, is that when you have an annular tear and a small herniation, you should get it fixed before it gets bigger. Yes, you should, because once it gets bigger, it gets a whole lot harder to treat, and there's more collapse of the disc, okay? Of course, the insurance companies don't want anyone to say that because they don't want to pay for the surgery. But the truth is that that is the best thing in the patient's interest. My fluid adapter disconnected. I'm just heading out to the side here, trying to get a little more exposure and decompression of this foramen on the other side. This is going to be his left C4-5 foramen right there. There's the annular tear right there. I'm debriding it with the laser. Remember, the PLL is behind that. I think that's pretty good. Yeah? All right. Took out a lot of pieces of herniation. I'm going to take one more look just to be 100%. Go back to the other side. Now here's an example of a bone spur we're not taking out. Why? Because it's not doing anything. Luis, I'm disconnected here at the fluid adapter. Don't push down. It's still on?
Yeah.
All right. I tried to get it reconnected, but I didn't know if I did. Scope on. All right. See, I'm lifting it and it's disconnecting. It's like disengaging. No, I'll do it. Okay, I'll do it. I'm just tired of dealing with this shit. All right. Any questions?
Yes, we have, I believe they're seeking for help or advice. This comes from Sharaf on YouTube.
Uh-huh.
And they said, my neck CT scan report said normal cervical lordosis, status post-anterior fusion at C5 to C6 along with disc repair. No significant subluxation. Remaining vertebral body heights are preserved. Disc osteophyte complex at C4.
Yeah, I'm not going to sit here and listen to a CT scan report. That's not what these broadcasts are for. This person needs to, you give him the link to do a virtual consultation. I'll give it to you. It's dukespine.com//VC for virtual consultation. Yeah, we don't do, I'm going to review your CAT scan in the middle of someone's surgery. Sorry. You need to fill out the form and you need to submit for a review. And we're going to give you the link to do that. But that's something I do during surgery on somebody else's neck. Okay?
We do have another question.
Sure.
This comes from Joshua Steinman on Facebook.
Uh-huh.
And
how's our irrigation? Well, I'm not able to float out this stuff. So, go ahead.
The question is, do you learn something new each procedure, or is it pretty simple for you now?
Yeah, Joshua, are the surgeries simple for me now? Well, we're operating on the spinal cord, above the spinal cord, the nerves. None of it's really simple. I make it look simple because I've done so many and I'm a very skilled surgeon. And the reality is, though, that this surgery looks simple, but it's not simple. It's minimally invasive. There's no bleeding. But all of that is because I do things the right way, if that makes sense. In other words, if I didn't put things in properly, there would be a lot of bleeding. There would be a lot of cursing. There would be a lot of, oh God, this is really bad kind of stuff. But because I do it properly, hold this. Because I do it properly, I do everything properly, we don't have those issues, okay? So it really does take a lot of finesse, which, if you're watching a soccer player like Messi, you don't really understand, unless you're a really good soccer player, you don't understand what he does with that ball, how he finesses it. All you know is he scores goals, gets around the defenders. But we're doing the same thing here. You're not seeing all the little details, the little footwork and the body work, the balance, the coordination, the planning. You don't see any of it. It's not obvious to people unless you're an endoscopic surgeon like me. But there's a lot of potential for very, very bad things to happen during the surgery. I just don't let them happen because I control the environment. I don't let it happen. I can let it happen, but I don't. I make a choice to not let it happen. All right, that's it. We're done. Looks good. Stop this. Go ahead and turn off the scope. Yeah, this just keeps disconnecting here, Luis. I don't know why. All right, great question. Any other questions? We're done. It was a single level. We're going to wake the patient up, and he's going to go home in about Oh, an hour from now?
Yes, we have a few more questions.
Sure. Why don't we hold them and let me come over there and answer them face to face. Okay? So type your questions up, folks. I'm happy to answer them for you. I'm going to show you in just a second here. No, we're done. I'm going to show you the actual incision. Oh boy. Sounds like a firework. Look at this, guys. Everyone see this? Can you all see this? Okay?
Yes, we can.
It's very important. All right, all these are little pieces of disc herniation, every one of them, that the laser was blasting and putting out, okay? And they just literally floated out. And here they are. So those are the ones that we didn't grab out with the grabber. Those are the ones that we floated out, okay? And that just shows you that there's a lot of fluid circulating down and out and pulling all the debris that the laser creates. This is all from the laser blasting little pieces of herniation out, and they float out. And they get caught right here, okay? There's like literally probably 50 pieces there. All right. Now, I'm going to show you in just a moment the actual incision once again, the 4mm incision. Our next surgery this morning is what?
Laser lumbar 2 levels.
Lumbar 2 level. So it's a patient with 2 herniated discs in his or her lower back, and they're having back pain and probably leg symptoms from a pinched nerve or irritated nerve. We're going to go in and do the Duke laser disc repair on the lower back. We always start our day with cervical because cervical patients require anesthesia, general anesthesia. That means they're intubated, they have a tube down. They take longer to wake up and recover, so we want to start them off in the beginning of the day so they have plenty of time to wake up. All right, there's the incision. You guys see it?
Yes, we do.
Okay. Again, that incision is 4mm. It's the only damage done to this patient's body. The rest of the stuff we do under the skin with the Duke laser disc repair doesn't damage anything. Okay? Other surgeries cause tremendous damage because the surgeon has to cut the tissues and cut open the neck, cut open the fascia, cut off the muscles from the front of the spine, damage the esophagus, which is your swallowing tube. That's why people have trouble swallowing. Do you know that the complication rate for an ACDF is 48%? That's 50%, folks. Half of the people having an ACDF are going to have a complication. That's published just recently. It's been part of my board, neurosurgical board course, board testing. We have to know that. Now, if you go in the back and you get a PCDF done, the complication rate for that is 25%. So, what's the complication rate for the Duke laser disc repair? 0. 16 years, we've done 1,600. We've not had a single complication. No voice injury, no recurrent laryngeal nerve injury, no esophageal injuries, no, carotid injuries, jugular vein injuries, no infections, because it's such a safe and minimally invasive procedure. It will be the procedure everyone does in the future. It's just a matter of demand from the public. The public has to say no more fusions, no more metal. That's what they need to do. All right, I'm going to call my EBL 1.5 mil. This was a DLDR. Left approach, everyone agree? C4-5. All right. Go ahead and type up your questions, folks. I'm going to come over there and answer them for you. We're going to show you a nice video of one of our patients who had recently had the surgery and let them share their experience. This is Dr. Aru Duke-Majan, CEO and founder of the Duke Spine Institute. I'm here with one of my patients, and you've traveled from where to the Duke Spine?
Idaho.
Idaho, with your lovely husband, and we've had a few conversations. She came here to have her back fixed. How long have you had back pain for?
For over 7 years.
Okay. And what kind of work did you do before you retired, if you don't mind me asking?
It was desk work.
All right. And so you had back pain for 7 years. Did you have an injury to your back, or did it just kind of gradually come on?
It just gradually came on. I actually noticed it first in 2015 when I was gardening and I couldn't be up there for 8 hours. I was into it for about 4 hours and I had to take a break. And as time progressed, my breaks got longer and longer, and the amount of work I did in the garden was less and less.
Understood. And you're retired now. So what's it like having back pain limit your ability to do stuff when you're retired?
For me, it's very frustrating. I can't do that what I want to do. So we kept seeking solutions and nothing was working. They did work for a short while, but that short while decreased over time. It was shorter and shorter. My husband does research very, very well. Through his research, he found you. We read that you can fix my back, and you did fix my back.
That's right.
And I thank you.
You're welcome. So when did you have the Duke laser disc repair done and the Duke plasma rhizotomy?
I had those done yesterday in the afternoon. I am sitting straighter than I have. I'm standing straighter. I'm walking normal. It's like, wow, new me.
Look at that smile right there. I hadn't seen that until just now. So
well, it wasn't there yesterday.
Yeah, it wasn't there before surgery. And how long have you been not smiling because you've been in pain? I mean, really bad pain. How long has the really bad pain been there?
The really bad pain has probably been over the last 5 years. It's something that was really tough to maintain a positive attitude and try to keep a smile on my face and keep, I tend to be a positive person, but there were times when it does drag you down.
Of course, yeah. It's hard living with chronic pain, and especially with loved ones, they have a hard time, relating. Of course, they want to be supportive, and your husband is a very supportive man, obviously. And he's a pleasure to meet. I know he's an author as well. Yes. And so what are you going to do now that you've had the surgery? And you could see actually the Duke laser disc repair procedure she had done yesterday. You can see right here, we went into the discs that were damaged. You had 2 annular tears. We tested your discs during the surgery, and indeed they were causing your pain. So we verified that with our discogram. And then I went ahead and used the laser to clean up the tears that were causing your pain and get rid of that source of pain for you. And here you are, you're doing fantastic. How much of your back pain from before surgery do you still have?
Oh, virtually nothing.
It's gone.
It's gone.
Cured.
My lower back, I have not been without pain in my lower back until your surgery. It's constant, it's always there. I've never been without it. I'm without it now.
So are you going to go back to gardening?
You bet I am.
All right, very good. And what other things would you like to do now that you have a new back that doesn't hurt you anymore?
The biggest thing I want to do? I want to go fly a kite.
Good for you. Let's go fly a kite then.
That's right.
Well, congratulations on having faith and being brave and getting it done.
Oh, not a problem.
Is there anything else you want to say to your fans out there?
I highly recommend Dr. Duke's Spine Institute, Dr. Duke personally, to help you fix your back.
Thank you. Appreciate that. All right. Safe travels.
Phew, that wasn't too bad, was it?
It was wonderful. Okay, I'm Dr. Duke Machen, and we're just wrapping up our first surgery of the day. This patient came in with injuries to several discs in his neck. He had an accident, he had a herniated disc at C4-C5, he has some degenerated discs as well. I felt C4-C5 was the worst one. He wanted to treat just the worst one. So we picked C4-C5 for him. Just got done. You could see endoscopically that C4-C5 had at least 20 or 30 pieces of herniation at that level. So point number one, everyone thinks about a disc herniation as being an event, one event. It's not. It's a multiple events. And I've got Carl here who's working on our new website. We're going to explain this in our new website. The first thing that happens is you get a tear in the wall of the disc from trauma, right? So a car accident, a slip and fall, a sports injury, jumping off the roof with a skateboard and hitting your head on the pool, all that trauma to the disc. The disc is a joint, it moves, it's between two bones. So once the disc has trauma, that causes a tear in the wall of the disc. I'm trying to find my pointer. All right, well, no pointer today. I guess I'll just use my God-given pointer. So here's the front of the disc, here's the back of the disc, here's the nerve, and this patient had a herniation in the back of the disc that was causing neck pain, and it was irritating the nerve going down his arm. We went through the front and we spread the fibers of the front of the disc, went through the jelly, got to the back. You saw us dock in the back, and I used the laser to zap out and remove all those pieces of herniation. There were at least 30 pieces of herniation, some small, some big. You saw them floating out. They're all about 3-4 millimeters, sometimes 2 millimeters, sometimes 1. But if they're really big, we have to take the laser and cut them in half so that they come out of the tube, because the tube is only around 3 millimeters wide. The laser fiber is 0.5 millimeter, just to give you a point of reference. Anyway, the surgery went perfect. At the end, you could see the fibers of the posterior longitudinal ligament running up and down, and I got all the herniation out from there. So I'm very happy with the way surgery went. We lost about 20 drops of blood, that's it. And the patient will go to the recovery area for about an hour and then go home. So this is an outpatient surgery. And the alternative, folks, would be to have a metal plate and a cage put in, or an artificial disc, or a posterior fusion. I'm going to tell you this. Lots of surgeons will do the fusions and the artificial disc. They actually pay them very well. They make a lot more money than I do. Why do I do endoscopic? Because it's better for the patient. Safer, faster recovery, better results. We haven't had a single complication in the cervical Duke laser disc repairs. I've been doing it 16 years. And safety, that's important, folks. If you're talking to your surgeon and they're not offering you the safest surgery in the world for you that has the best results, then you need to look elsewhere. Don't settle for bad surgery. I'm going to tell you something. There's bad surgery and there's bad surgeons, and there's lots of them. And that's why we do our broadcast, so you could see the most advanced spine surgery in the world. You could see it being done every week at Duke Spine Institute. You could see the results. Okay? All right, we'll take our first question.
Yes, our first question comes from Amanda Green on YouTube. And
Hi, Amanda.
They asked, to help the patient, why not do the other disc, especially if they aren't able to afford it? Rather than making someone come back for surgery later on, why not go ahead and fix the other side also if you can see more of the herniation?
Hey, that's a great question, Amanda. It's not about me. It's about the facility and keeping our doors open. We have very high costs. They need to be paid. There's no charity. We don't have Bill Gates donation or Elon Musk. So Amanda, if you're so concerned about the patient, send us some money and we'll bring this patient back and take care of the other discs. But the problem is that people think healthcare is free. It's not free. Healthcare should be free for everybody. That's my opinion. However, it's not. And that's out of my control. That's you, Amanda. You and your friends have to go talk to the politicians and get the politicians to make laws that allow the insurance companies to pay for these surgeries or force them to pay for the surgeries so that the patients don't have to. All right? What we're seeing in healthcare in the insurance side is the insurance companies are denying more and more treatments. They're denying treatments they used to cover years ago that we never had problems getting covered. They don't want to pay for it. And the surgeries that they're paying for, they're actually supposed to send in $1,000. They'll send in $20. All right? And then you have to have your staff fight them. So all of that costs tremendous amount of money. Overhead, runs close to $1 million a month. And where is that money going to come from if it's not from the people who are getting the surgery? So I'm glad that you feel that way, that patients shouldn't have to pay for their surgery. I love it. I don't think they should have to pay for their surgery either. But I'm waiting for a solution. So please bring me one. Thank you.
All right, next question is from Roshan on YouTube. and they say, "Hello, Dr. Du. When did you realize that spinal surgery slash neurosurgery was your passion? And if you can go back in time, what's one piece of advice you give yourself in medical school?"
Sure. Well, welcome to our broadcast, Rashawn. Thanks for being here. I've told my story a few times. I'll just give it quickly in a summary. When I was in college, I thought I was going to be a professional soccer player, except there was no path to professional soccer back in the early 80s. This is like 83, 84. So I decided to go to the university, and when I got to the university, I really wanted to be an anthropologist, sociologist, and study societies and culture and evolution and things like that. It was very fascinating to me. However, there were no jobs. So I ended up looking at other opportunities. I became a chemistry double major, and basically pre-med, and I followed my father's footsteps into medicine because he loved medicine. He wasn't a surgeon, he was an OB-GYN, which is quasi-surgery. Anyway, so I went through college, the latter half of college, focused on getting into medical school. I eventually got accepted and matriculated to USC in Los Angeles. When I went to USC, because I had an athletic background, I was an athlete, and I liked the idea of doing surgery, and I was, smart enough to get into a surgery residency. I decided I was going to be an orthopedic surgeon, and I was going to do orthopedic surgery. And USC in Los Angeles is one of the top orthopedic surgery training programs in the world. So I started to watch the surgeries in orthopedics, and honestly, I got turned off right away. I just didn't like it. It wasn't interesting. Then I started studying the brain and the nervous system. I realized that was my passion. So I realized surgery, brain surgery. So I ended up applying for neurosurgery, got in, and at that time, I thought I was going to be a pediatric neurosurgeon. That's what I wanted to do. Follow Ben Carson, learn from him. I interviewed with him at Hopkins, and then decided that was not, I didn't want to put myself in a situation where I had to be a pediatric neurosurgeon and had no other choice. So I went to the best training program at the time in the world, University of Florida in Gainesville, and I decided I'm going to get trained in everything in neurosurgery. And I'm going to be good at everything: clipping aneurysms, AVMs, skull-based surgery, spine surgery, pediatric neurosurgery, radiosurgery, everything. And of course I got that experience there. And then I met a top spine surgeon trained at the Barrow Neurological Institute, Phoenix, Jeff Henn, and he started to do the most advanced spine surgeries at the time. This was in around 2001, 2002. And one thing I saw was that the patients who had spine surgery actually did really well. Like all the other neurosurgery patients, pediatrics, adults, skull-based tumors, they had horrible complications. They had horrible outcomes for the most part. Very few of them did well. Even aneurysms, unruptured, came in and they would have complications, from surgery. And they would die, basically, or be paralyzed. So I really started to personally appreciate, professionally appreciate spine and the great outcomes spine patients have. Now, at that point, I decided that I was just going to go into private practice. I had also gotten an NIH grant to do research on epilepsy in the brain. I even published a paper with my mentor, who is the head of epilepsy at Shands Hospital in the epilepsy program, Steve Roper. We did a study on cortical dysplasia, which is like the third most common cause of epilepsy, and we were looking at neuronal migration in the fetus from the germinal matrix out to the cortex. And I was studying these cortical dysplasia, which is an abnormal hierarchy or architecture of the cortex, and actually discovered that there was a loss of inhibitory interneurons in rats with cortical dysplasia, the model. So that was a big discovery, and I was supposed to go into epilepsy, but I got turned on to spine. So all I can say is I didn't start out thinking I'm going to be a spine surgeon, knowing I'm going to be a spine surgeon. I had no idea I was going to go in spine. As a matter of fact, if you told me I was going to be a spine surgeon, I would say, hell no. There's no way I'm going to do spine surgery. I'm not even interested in it. So all I could tell you is be open-minded, and if you know you want to be a surgeon, that's one thing, that's good, and that'll push you in the field of surgery. But figure out what you like treating, what kind of patients, what kind of disease, what kind of conditions. What do you find interests you the most? Because ultimately, you have to live with that decision. And I know lots of people who have changed their minds way, way, way late in the game after undergoing fellowship training, and they're not happy with what they're doing. My advice to you is spend some time, learn about these different areas of the body, and don't do something because it's prestigious. Do something because you love it. You have a passion for it. You have challenge with it, and you want to make it better. You want to do it better than everyone else. That's what I would say.
All right.
And so the advice in med school, get the highest grades you can. I was the valedictorian in my medical school. I was #1 in the class. I had students from Harvard, Hopkins, Columbia, San Francisco, UC San Francisco, all the UC systems, and I was just studied all the time, got the best grades. Whatever you decide you want to do, you want to be in a position where they can't say no to you, where they're going to have to accept you because you're a top student. That's my best advice.
All right. Next up, we have a comment from Cheryl on YouTube. And they said, I love and appreciate your straightforwardness. You don't sugarcoat your answer, just like your work. Keep up the good work.
Hey, thanks, Cheryl. Yeah, here's the thing. Unfortunately, medicine has a lot of liars and scammers, okay? And I didn't know that when I chose to go into medicine. And I'm not just talking about doctors, I'm talking about therapists, chiropractors. Every part of medicine has people that prey upon the patients and prey upon the patient's misfortune. I was brought up better than that. My father taught me to treat everybody with respect and to really do your best for the patient as a doctor. And he taught me that when I was young. And he spent a lot of time investing his time in bringing me up the right way, okay? And so over the years, what I learned to do was to accept the truth for what it is and not try to lie or hide the truth. When the patient has a problem after surgery, I learned to face the problem, understand the problem, and figure out what my role in either creating the problem or solving the problem was. And so when you do that, you have to face the truth. And the truth is that sometimes as doctors, we make bad choices. And so the moment you understand that you as a doctor have a tremendous impact on how the patient does, obviously if they're listening to you and they're doing what you ask them to do, then you have that responsibility to them to do the best for them, which means you have to stop and go back and analyze what you did and how could you do it better. And that process of what we call root cause analysis is how successful people in life solve problems. And so I took that process and I applied it to spine. And what I learned was that, there were things that everyone is doing wrong in spine. A lot of things that doctors are doing wrong, okay? And I started to understand what we were doing wrong, but more importantly, what needs to be done to make it better. And I started to make those changes in how I treated patients, whether diagnostic or treatment-wise or education-wise. I looked for my failures and what caused the failure, analyzed it, and improved upon it, okay? I'll give you an example. When I first started, there's so many examples, I can give you hundreds, that if all these things that I tackled and changed and modified have led to where we are today. And there's thousands, okay? One example, nerve test. It's called an EMG nerve conduction study. I need that test in patients. In the very beginning, when I started in 2004 on private practice, I would tell a patient, you need a nerve test. And that was it. And guess what? They would come back and more than half of them would not get the nerve test. And I would say to them, why didn't you, I mean, most doctors don't like talk to their patients that well. I said, why did you not get the nerve test? And the answer I kept getting, two answers. Number one, I didn't understand why I needed it. And number two, I couldn't afford it, all right? So the couldn't afford it part, not much I can do about that, right? I just can't, you know? But I don't understand why I need it. I realized that was a failure on my part to educate the patient. I wasn't teaching them why they needed the nerve test. So from that point on, once I realized that, I started to spend 2 minutes with each patient saying, you've got nerve damage. We can see it on your exam. We don't know why. And we need to know, is it from a pinched nerve? Is it from a neuropathy? Is it from a peripheral nerve being pinched? Is it from a herniated disc pinching the nerve in your back? So the nerve test helps us figure that out so we could do the right treatment for you. Once I took a minute to explain that to the patient, the compliance went up to about 80%. So it went from 50% to 80% right there. So what I'm getting at is it's those kind of things that over time I've taken on these challenges. Rather than burying my head in the sand and ignoring them like my colleagues do, I've actually decided to fix them. Another example is after PCDF, posterior cervical laminectomy and fusion surgery, okay? Every patient gets horrible neck pain, horrible. And I asked my professors at neurosurgery, what do you do about it? And they said, send them to pain management. Well, that's not really anything because pain management is just going to give them pills and do shots, and that's not fixing it, right? These people are in pain the rest of their lives after the surgery. It could be 30 years, 40 years. But nobody seemed to have an answer. So I traveled the world. I asked every spine surgeon around the world that did these types of surgery, what do you do? And they all just laughed and said, there's nothing you can do, right? So then I started to really think about it. What's causing the pain? And I realized what's causing the pain is two things. Number one, it's the shape of the spine at the end of the surgery. It's called alignment. So I started to push the head back and get them straight, kind of like curved back, but kind of like not kinked forward. And when I did that, the results improved. And then the thing I did the biggest, I realized it was the muscles that were dying after surgery that were causing, you know, the pain that lasts forever. So what I started doing was I started protecting the muscles during surgery. And by doing that, we kept the muscles alive in the back of the neck, and the pain went away right after surgery. So I made some changes and solved that problem. And that's my practice. It's what Duke Spine represents, solving problems for patients. And I've been doing that now for 20 years, and we've solved just about almost every problem, except we don't solve insurance problems. We're trying to, but patients need to solve the insurance problems. All right, what's the next question?
The next question is from John Michael Clutter on
You get
Facebook.
Coffee, fresh.
Oh.
Yes, John Michael.
And they asked, do damaged discs affect the ligaments in your neck that cause them to become stiff and sore?
Do damaged discs affect the ligaments in your neck that cause them to become stiff and sore? No. Damaged discs cause pain. The pain causes stiffness because you don't want to move your neck because it hurts to move.
And that is it.
Great. Hope you enjoyed this broadcast. We'll be back probably in about 20 minutes, and we'll be having a lumbar Duke laser disc repair.